Thank you, Dr. Black. So before I start this presentation, I just want to say thank you to both Dr. Kavanagh and Dr. Stothers for the help with this presentation. So the objectives of this presentation are to review the diagnostic approach and evaluation of patients presenting with recurrent uncomplicated urinary tract infections, to understand the pathophysiology and predisposing factors to rUTIs, to learn about the current and emerging non-pharmacological as well as pharmacological therapies that can be used in the prevention of recurrent UTIs, as well as to review some of our own local antibiograms and highlight some of the resistance pattern. So here are some definitions that will be important for this talk. So first of all, before we can say that a patient has UTIs, there has to be a positive urine culture that is present essentially during each episode of symptomatic cystitis. So when we talk about an uncomplicated UTI, this refers to an episode of acute cystitis in an otherwise healthy host that has anatomically and functionally normal urinary tract system, meaning that they don't have a history of stones, diverticulum, or neurogenic bladder. When we talk about recurrent uncomplicated UTIs, we're referring to patients that have had 2 or more episodes of UTI in the last 6 months, or 3 or more episodes in the last 12 months. So I just want to note here that if there is a rapid recurrence, meaning that within less than 2 weeks following treatment of a UTI, a patient has another episode, then they should maybe be worked up as having possibly complicated UTIs as an underlying issue. And finally, when we're referring to complicated UTIs, it's usually a UTI that is occurring in an immunocompromised host or a patient with anatomical or functional anomaly of their urinary tract system, or if a multi-drug resistant bacteria is involved. So just to give a little bit of background here, we see that UTIs are very prevalent. They represent 12 to 15% of visits by women to their primary care physicians, and approximately 40 to 50% of women will have had a UTI in their lifespan. And of those women, 30 to 50% will have a recurrence in the first year. In Canada, UTIs also represent the 5th most common reason for a visit to the emergency department and the 8th most common reason for an ambulatory visit. And we also see an increasing incidence in postmenopausal women. And with UTIs, being so common, they also generate very high cost of treatment, which have been quantified to be upwards of 50 million euros in France per year, and up to 2 to 6 billion per year in the US. So when it comes to predisposing factors for recurrent UTIs, we'll usually see that they vary based on the age groups. In younger sexually active women, we'll see that intercourse and spermicide use being present in several women with recurrent UTIs. But in older postmenopausal women, the lack of estrogen will play a larger role in their risk of recurrence. Obesity has also been associated with an increased risk of recurrent UTIs in both men and women. And there was actually a study that showed that when we control for both age and diabetes, obese women were 1.25 times more likely to develop UTI in comparison to patients that had a BMI less than 25. So in the diagnosis of recurrent UTIs, obviously a complete history and physical examination should be undertaken, but we should also perform a pelvic examination in female patients. So in order to make a diagnosis of recurrent UTI, as we've mentioned, we do need a positive urine culture with every symptomatic episode of suspicious for cystitis. In the differential diagnosis, we also need to rule out overactive bladder because patients with OAB will usually present with LUTs, including frequency, urgency, nocturia, but usually they won't have dysuria or hematuria, which is frequently seen in patients with UTIs. There was actually a review study that showed that most women presenting with LUTs are treated preemptively with antibiotics for UTIs. But when their cultures were obtained, less than half of these women indeed have bacterial growth in their urine, meaning that we're somewhat over-treating patients presenting with LUTs. Something else that I want to touch on here is the significance of mixed flora in urine cultures. So the grand majority of the time, it represents a contaminant from the surrounding vulvar tissues and shouldn't be treated if the patient is asymptomatic. And it was actually a trial that compared preoperative cultures for patients undergoing urogynecological surgery and found that really there wasn't any difference in the UTI rates postoperatively between patients that had mixed flora in their pre-op urine versus those that had a no growth. But I also want to note here that if patients are symptomatic and they do have several urine cultures that are showing mixed flora, they should be treated. And this also applies if they do have the same isolate in their urine cultures and blood, but those would usually be sicker patients. So there are also certain elements that we need to pay particular attention to when examining postmenopausal women presenting with UTIs to identify if they have vulvovaginal atrophy. So in these photos at the top here, we can see that the skin is pale and smooth. And we'll also see thinning of the vaginal wall with loss of elasticity. And as you can see on the picture here labeled as C, the skin surface is quite friable and can bleed with really just minimal trauma. On the bottom here, bottom left here, we can see histological slides of vaginal mucosa where there is a marked thinning of the epithelium in the context of vaginal atrophy. And on the right-hand side here, we do have a photo of what a normal epithelium looks like. And typically, this is what the epithelium will look like after treatment with topical estrogens. And a good way to explain this to patients is to tell them that a healthy vaginal mucosa will be pink and spongy and will be kind of like the inside of the mouth, as opposed to dry and white, like we can see in these photos. So now let's look at the evaluation for recurrent UTIs and the need for cystoscopy. So there are going to be two studies that I'm going to focus on here. So there was a review that was performed by Santoni and colleagues where they pulled data from 7 studies, totaling 656 patients that underwent a cystoscopy. Of those, 151 or 23% had an abnormal finding. However, only 19 or 2.89% of those findings were of clinical importance, meaning that they likely required more investigation or treatment. And I just want to note here also that the most common finding was that of inflammation, which is not only common, but also expected in the acute cystitis episode. So Pat and colleagues also performed a retrospective cohort study looking at 593 patients with a history of recurrent UTIs across 2 different hospitals. And in their studies, cystoscopy was performed in 379 patients. And of those, abnormal findings were noted in 144 patients. Again, in the study, the most common finding was signs of inflammation, but they found that 6 out of the 144 patients had a treatment-altering finding that led to a TURBT and 5 urethral dilations. So these same studies also looked at the role of imaging in the evaluation of recurrent UTIs in women. So the review performed by Santoni and colleagues pulled data from 8 studies, totaling 785 imaging studies that were performed either in the form of IV urogram, which is no longer a routine imaging study, abdo X-ray, or ultrasound. And of those 785 imaging studies performed, 71 were found to be abnormal, and of which only 10 were deemed to be serious anomalies, of which 40% were actually gynecological and could have been diagnosed clinically, like an ectopic or intrauterine pregnancy. And in fact, only 3.8% required further urological follow-up, mostly for stone disease. In the Pat and colleague cohort study, imaging was performed either with ultrasound, abdo X-ray, or CT scan. And 35 out of the 284 abdominal X-rays were suspicious for stones. 97 of the 447 ultrasounds were found to have anomalies, including unilateral hydronephrosis, stones, renal bladder tumors, or incidentalomas in 14% of those. And out of the 89 CT scans that were performed, 40 were flagged as abnormal, with most of them detecting renal tumors, stones, and incidentalomas in 35%. And then I just want to highlight here that, again, only a minority of the findings detected by ultrasound or CT changed the management of patients or required further investigation or referrals. So next in the evaluation of UTIs, we'll talk about urodynamic studies. So in terms of that, again, the same 2 studies have looked at this, and the Santoni and colleagues review pulled data from only 2 studies, totaling 203 patients. And within those studies, only flow and PVRs could be compared because the Truser abnormality, overactive bladder, and stress incontinence were not reported by the Raz and colleagues. So that prevented the comparison of these factors between the 2 studies. In terms of urine flow, they did report that it was abnormal in about 50% of patients, and PVR was noted to be positive or abnormal in 35% of patients. But there was a bit of inconsistency in their definition of what a positive PVR represents. And lastly, in the study that was performed by Pat and colleagues, they looked at flowmetry, which was performed in 409 patients, of which 193 were abnormal. And dysfunctional voiding was noted in 112 of these patients, with a flattened curve noted only in about 4 of them. So here, when they looked at post-void residuals, they measured it in 515 patients, and it was found to be abnormal or greater than 150 cc's in 18 of them. And these findings were treatment altering for about a quarter of the patients, with 86 of the patients being referred to physiotherapy, and 14 of the total patients with anomalies being thought had to perform CIC. So when we look at the AUA, CUA, and SUFU guidelines, cystoscopy, imaging, and urodynamic studies are not recommended in patients with recurrent UTIs unless there is a suspicion for a complicating factor. So now I'm going to quickly go over the pathophysiology underlying UTIs. So Uropathogenic E.Coli is the most common community-acquired cause for community-acquired UTIs, accounting for about 80 to 90% of UTIs in the community. Although, as we know, other pathogens like Klebsiella, Proteus, and Enterococcus are also fairly common. I just want to attract your attention here to the structural components of the bacteria. So the type 1 pilus and the FIMH here represent one of the mechanisms by which bacteria will adhere to the bladder epithelium. Similarly, adhesins, as we see here and here, also represents other means by which the pathogen will adhere to the bladder walls. And finally, the flagella is the main mechanism by which the bacteria will acquire its mobility. So the infectious process starts with UPEC colonization of the vaginal and periurethral areas. And then the bacteria will ascend into colonization of the urethra will occur before the bacteria ascends into the bladder. And then the type 1 pilus present on the bacterial surface, as we discussed, will adhere to the uroplakin 1A here that is noted on the superficial umbrella cells of the bladder epithelium, and that'll lead to bacterial internalization. Then UPEC will multiply to form intracellular bacterial communities, or IBCs. And then finally, what happens is we will see the efflux of UPEC from IBCs, and that will result in the reinvasion of the nearby cells and the formation of quiescent intracellular reservoirs in the transitional cells, which can remain actually in the host cells for several months. So now that we've talked a bit about the pathophysiology underlying the infection, I think it's also important to address how the infection gets there in the first place. So at the top here of the illustration, we can see what a healthy gut, vagina, and bladder interaction is like. So when the gut is healthy or asymptomatic, the microbiome is stable across individual conditions. These microbiota protect their host-associated niche from foreign pathogens by controlling abiotic factors and outcompeting the potentially invasive microbiota that would cause an infection. So microbial dysbiosis, which we can appreciate here at the bottom of the illustration, occurs when there is an adverse environment change that'll disrupt the host homeostasis, like, for instance, poor hygiene, metabolic changes like menopause, or exposure to environmental metals or antibiotics, or consumption of foodborne pathogens. So this allows for the microbiota to transition between the perianal to urogenital pathway, and in turns will shape other microbial communities towards dysbiosis and will predispose individuals to UTIs by the pathophysiological mechanisms that we've discussed in the previous slide. So in terms of the bacteria being present across the different systems, previous evidence suggested that perhaps women with UTIs have a different strain of UTIs in their urine and their gut. But Magruder and colleagues performed a study to assess whether the gut microbiota is a risk factor in the development of recurrent UTIs by collecting paired urine and fecal samples. And they compared strain analysis, uropathogenic genes, and antimicrobial resistance genes, and found that the E. coli strains between the gut and the bladder were closely related, which really just further supports the hypothesis of a gut microbiota UTI axis. So now that we've talked about the pathophysiology and relationship between the environments, let's talk a bit more about the host defense mechanisms that are at play when the infection first occurs. So there are either pathogen-associated molecular patterns, or PAMPs, or molecules derived from damaged or dying cells, which are danger/damage associated molecular patterns, or DAMPs, that will be recognized by the PRRs, or pattern recognition receptors. So these PRRs are able to recognize PAMPs or DAMPs in specialized immune cells, the epithelia, or other tissues. And when that happens, this is essentially there is then an assembling in the cystosol of inflammasomes, which will then trigger innate immune system through various mechanisms depending on the production of pro-inflammatory cytokines. After UPEC enters the bladder epithelium, utilizing fusiform vesicles, as we can see here, it will rapidly replicate, resulting in the maturation of intracellular bacterial communities, as we've mentioned previously. So tool-like receptor 4 belongs in the family of pattern recognition receptors, or PRs, and they will recognize PAMPs And this represents kind of the first line of defense against the infection. So tool-like receptor 4 will increase intracellular cyclic AMP levels, and that triggers the exocytosis of the fusiform vesicles, like RAB27B+, that we can see here, which harbors UPEC. This leads to the intracellular bacterial expulsion back into the bladder lumen. And then we'll see that tool-like receptor 4 also induces the production of very soluble factors that are secreted by the bladder epithelial cells, including antimicrobial peptides, proteins, and chemokines. Something else that I want to discuss here is the role of uromodulin, which are high mannose containing glycoproteins that also exert a protective effect against UTIs by competing with the binding of UPEC, FIMH, on the type 1 fimbriae to type 1 pilus, to uroplakin 1A. And what that does essentially is limiting the introduction of the bacteria into the epithelium in the first place. In the context of an acute infection, we'll also see exfoliation of the epithelium and rapid renewal of the epithelial surface. So now I'm going to move on to the second part of this talk, which will focus on non-pharmacological prophylaxis for recurrent UTIs, namely lifestyle and behavioral modifications, Cranberry products, and proanthocyanidins, D-mannose, as well as methenamine. So when patients are referred for recurrent urinary tract infections, more often than not recommend that they adopt some lifestyle changes and behavioral modifications, usually centered around personal hygiene and previously identified factors like wiping front to back after a bowel movement, avoiding hot tubs, baths, using tampons instead of pads, and cotton underwear, as well as avoiding tight clothing. But what I want to highlight here is that case control studies, such as the one that we are including here on the slide, have demonstrated that there is a statistically significant difference between women who use spermicides for contraceptions and those who don't in their chance of developing a UTI. Differences were also noted in the use of non-cotton tights, but this wasn't observed in any other risk factors like water consumption or personal hygiene. I also want to make note here that both oral hydration and avoidance of spermicide are mentioned in the AUA, CUA, and SUFU guidelines as points of discussion with patients, but the evidence in support of this really isn't great. And there's also no specifics in terms of how to counsel patients about these different risk factors. So now I'm going to talk a little bit more about the evidence around the use of Cranberry products and proanthocyanidins, otherwise known as PACs. So one of the proposed mechanisms of action relates to the fact that cranberries contain fructose, which has been found to have a role in inhibiting the adherence of E. coli type 1 fimbriae to urothelial cell receptors in vitro. PACs are also thought to directly bind to the P. fimbriae present on the bacterial wall, thus preventing its binding to the glycolipid receptors on the cell surface. I also want to highlight here that not all PACs were created equal, and it's really the type A PACs that are found in Cranberry products that'll affect E. coli adherence, as opposed to the type B PACs that are found in other commonly consumed products like chocolate or apple juice. So Cranberry products are available in various forms. So we can find them in tabs, powders, juices. And there's also evidence that consuming the frozen raw fruit can also achieve good concentration of PACs in the urine. But because there's a lot of heterogeneity across different trials, there isn't any specific dose, regimen, or formulation that has been recommended by the guidelines. A trial that was performed by McMurdo and colleagues compared daily cranberry supplements to low-dose trimethoprim and found that antibiotics only have a very limited advantage over cranberry extract, with patients in the cranberry group having a 60% higher chance of developing UTIs, but this wasn't found to be statistically significant. There was also another trial that was performed by Burput and colleagues that compared cranberry supplements with Septra prophylaxis over the course of 1 year and found that the Septra was a superior agent, as evident by lower, as we can see here, lower mean of numbers of clinical recurrence at the expense of increased antibiotic resistance. But I also want to point out that in this study, they used a dose of Septra prophylaxis that is a little over double actually than what is recommended by the AUA, CUA, and SUFU guidelines for daily Septra prophylaxis. I also want to highlight here some of the evidence that was generated from a trial performed here at UBC. So this trial compared the use of cranberry juice or cranberry tablets with placebo, in a randomized double-blind study. So 150 sexually active women that had at least 2 microbiologically confirmed symptomatic UTIs in the past year, between the ages of 21 and 72, were included in this study. And women were randomized to receive placebo juice plus placebo tablets, placebo juice plus cranberry tablets, or cranberry juice plus placebo tablets. And there were 50 women in each group. And the tablets were taken twice a day, as opposed to the juice, which was provided 3 times a day, 250 cc's. There was a significant reduction in the proportion of women experiencing symptomatic UTIs during the 12-month follow-up period in the cranberry juice and the cranberry tablet groups compared to placebo. And actually, the decrease was greater than 50%. The mean number of UTIs in the year after treatment was also statistically significant, again favoring the cranberry products group. There was also no significant difference in the rate of reported UTIs that was observed between the cranberry juice and the cranberry tablet group. And there was also a cost effectiveness analysis that was defined, where cost effectiveness was defined as dollar cost per UTI prevented. And cost effectiveness ratio for tablets was $1,890 per UTI prevented, with 73% being related to direct patient cost, 5% indirect patient cost, and 21% direct healthcare sector costs. So D-mannose is another product that has been studied as a potential prophylactic agent for recurrent UTIs. So D-mannose is similar in structure to the binding site of urothelial glycoprotein receptors like uroplakins, and therefore can cause saturation of the FIMH adhesins, which are at the tip of the type 1 pilus in UPEC. And that would prevent the bacteria from binding to the urothelial glycoprotein receptor if present in sufficient concentration in the urine. An RCT was conducted by Kranjak and colleagues and assessed the efficacy of D-mannose versus nitrofurantoin versus placebo in preventing recurrent UTIs. And the number of recurrent cystitis episodes was significantly higher in the no prophylaxis group as opposed to the D-mannose and nitrofurantoin groups. Patients in the D-mannose and nitrofurantoin groups also had a significantly lower risk of recurrent cystitis episodes during the prophylactic therapy compared to patients in the no prophylaxis group, with an absolute risk reduction of 45% compared to the control group. And then the difference between D-mannose and nitrofurantoin groups wasn't found to be significant, as we can see here. No, as we can see lower down, sorry. And I also want to make note here that although D-mannose is mentioned in the guidelines, the evidence is not strong enough to issue a formal recommendation on its use at this time. Lastly, methenamine is also another agent that has been studied as a potential prophylactic agent. So when in an acidic environment, methenamine is hydrolyzed into ammonia and formaldehyde. And it's thought that formaldehyde inhibits cell division by preventing nuclear and cytoplasmic synthesis. So therefore, it acts as a bacteriostatic agent without breeding resistance. And actually, a recently published RCT was conducted by Harding and colleagues, where 240 women with a history of UTI were assigned to either the methenamine group or low-dose antibiotic prophylaxis with trimethoprim or cephalexin. And their predefined non-inferiority margin was that of 1 urinary tract infection per person year. And the incidence rate of symptomatic antibiotic-treated urinary tract infection decreased substantially in both arms to 1.38 episodes per person year for the methenamine group and 0.89 episodes per person year in the antibiotics group, with an absolute difference of 0.49, which was within their accepted range. Methenamine, again, is mentioned in the guidelines, but due to insufficient data, there's no recommendations that have been made. So the next part of this presentation is going to focus on pharmacological therapies for recurrent UTI prophylaxis, namely estrogen for postmenopausal women, vaccines, and immunostimulants, as well as antibiotics. So lack of estrogen is one of the main physiological changes noted post-menopause. So decreased levels of estrogen have been associated with reduced urinary flow and increased residual volumes. And there's also evidence, as we've previously discussed, that lower estrogen levels can lead to microbiota dysbiosis, and that'll lead to an increase in vaginal pH and loss of commensal lactobacilli in the vagina, which will ultimately increase the risk of developing urinary tract infections in postmenopausal women. So estrogen promotes commensal lactobacilli, which then prevents colonization by gut pathogen, therefore reestablishing host homeostasis. The evidence, though, is very clear when comparing oral versus vaginal preparations, in that oral estrogen does not decrease the rates of recurrent UTIs or increase commensal bacteria. So it is not recommended for this indication. There was a randomized control trial that was performed by Ferrante and colleagues, where women were assigned to either vaginal estrogen in the form of a vaginal ring or cream versus placebo. And their result showed that there was a statistically significant decrease in the rates of UTI in women who had been exposed to estrogen. They did report that only 50 to 53% of women had a UTI recurrence on the estrogen group, as opposed to 91 to 94% of women in the placebo group. There's also no statistical difference between UTI recurrence between the vaginal ring versus vaginal cream groups. So when it comes to deciding what the best formulation is, there's a lot of heterogeneity in the data and across different trials. There was a systematic review that was conducted by Ron and colleagues, and they reported that there was insufficient data to recommend one formulation over the other. But then a Cochrane review did suggest that perhaps a vaginal cream is preferred to vaginal rings. The guidelines do provide several options, as we can see on this table down here, but they don't recommend one topical formulation over another. And instead, they advise for shared decision-making between provider and patients and seeing kind of what the patient prefers to have, and especially if they will be the ones applying it on their own. So when it comes to recommendations on how to apply the cream, clinicians can advise their patients to apply a blob of estrogen on their finger before applying it around the urethral and vaginal area. And oftentimes, this will be done nightly for a couple of weeks, and then about twice a week for the next 6 months or so. And I just want to highlight here that although the systemic absorption is thought to be minimal, topical estrogens are contraindicated in women with undiagnosed abnormal genital bleeding, women that are suspected or currently have breast cancer, or any other estrogen-dependent malignancy, as well as patients with either a current DVT or PE or a history of these conditions. So it's important to elicit those things on history. Now I'm going to talk a little bit about immunostimulants and vaccines. So immunostimulants are thought to activate both the innate and adaptive immune systems after being ingested. And immunostimulants have been shown to activate dendritic cells, neutrophils, and T helper cells. And this activation then results in the activating of T lymphocytes and B lymphocytes, leading to the release of IgA, which then results in immunoprotection. So the first agent we'll be talking about is OM89 and OM89S. So the form of this is an oral capsule, which is taken daily for 3 months. And it basically contains 18 strains of heat-killed UPEC. So Burput and colleagues published a systematic review of 4 randomized placebo-controlled trials investigating OM89. And this included 891 patients with recurrent UTIs and showed that OM89 had a significant efficacy as a prophylactic agent in this patient population. And there's also some evidence that it also reduced antibiotics prescription. However, a subsequent large trial of 451 patients with recurrent UTIs did not demonstrate benefit in the use of OM19S as prophylaxis, but also didn't show the efficacy of nitrofurantoin for prophylaxis. So it's unclear if this is indeed related to the agent or just the growing resistance patterns in these UPEC strains. So the next agent we'll talk about is Strovac, which is available as an intramuscular injection or a vaginal preparation. With the intramuscular, some side effects have been noted. So it's another immunostimulant that has been previously studied, contains 6 strains of UPEC, but also Proteus, Klebsiella, and Morganella, and Enterococcus. And there is some evidence that showed modest efficacy, but the highest benefits were seen with monthly boosters. Now, the last agent is Urimune, or MV140. It's another immunostimulant that contains inactivated E. coli and other common pathogens. And it comes in a form of a spray that is applied twice daily sublingually for 3 months. So several cohort studies have demonstrated its efficacy with an absolute risk reduction of UTIs of 90%. And there's actually been a new drug submission to Health Canada in March 2022 for Urimune. So it's potentially something that we will see available in the near future in our Canadian market. It's already approved and recommended in Europe. Now, I just want to discuss a little bit about antibiotics' role in the prevention of recurrent UTIs. So if we look here on the right-hand side, there is a table of suggested and recommended, actually, antibiotic prophylaxis dosing and agents as per the AUA-CUA and SUFU guidelines. Now, there are different ways to advise patients for prophylaxis. One of them is postcoital prophylaxis, which is most appropriate for women that have a clear history of recurrent UTIs post-sexual intercourse. We can also sometimes offer self-directed approach, essentially where patients will self-diagnose when they have symptoms of a UTI and start a very short course of antibiotics at the very onset of their symptoms. But when we do offer this, we should still advise them to provide a urine culture when possible. And lastly, when we look at continuous low-dose antibiotic prophylaxis, well, we have to select, first of all, the antibiotic agent based on the previous cultures. It also usually takes around 3 months before we can see its effectiveness. And the guidelines recommend that if we expect the duration of prophylaxis to be greater than 12 months, then we should probably consider agents like nitrofurantoin, Septra, or trimethoprim, as opposed to quinolones that have an increased risk of resistance. So is there one regimen that is better than the other? The data is limited and somewhat dated, but supporting that postcoital, but does support that postcoital antibiotics are superior to placebos. And then when postcoital Cipro was compared to daily Cipro, the rates of recurrence weren't different between the two, and the postcoital group used actually only a third of what the daily group used. In terms of self-diagnosis and self-treatment, there's trials that show that women are actually pretty good at self-diagnosing their UTIs, and those UTIs were appropriately treated in a majority of patients. But if we're going to offer this method to patients, they really need to be well educated on how to self-diagnose and really actively be engaged in their own management and treatment. So the guidelines say that, antibiotic prophylaxis can be offered to patients with recurrent UTIs daily for 6 to 12 months. And then if recurrent UTIs are really associated with post-sexual intercourse, then we can offer postcoital prophylaxis. And the main benefit of doing that is decreased GI symptoms from the antibiotics. Now, I just want to show here this flow chart in the guidelines that kind of highlight what we've already discussed. But I just want to mention here that it is obviously a resource that is readily available that we can refer to very easily in the clinic. Before I talk about the antibiograms, I just want to briefly review the mechanisms by which bacteria develops resistance. So with increasing antibiotic use in humans and animals, bacteria is exposed to increasing agents and will develop resistance through successive mutations, chromosomal mutations, and mobile genetic elements like transposons and plasmids that we can see here up on the image. So mobile genetic elements enable a really rapid spread of resistance between bacteria. And then resistance through all of these mechanisms will increase under the antibiotic pressure with positive selection. Resistance mechanisms can then act to inactivate an antibiotic, alter its concentration at the point of action, or even modify the target of the antibiotic. So up top here, we have conjugation, which does require cell-to-cell contact to transfer DNA from one bacterial cell to another, as opposed to in transduction here, where bacterial DNA is transferred from one cell to another by phage. And then finally, in transformation, DNA released from one bacterial cell is taken up by the next one. And both transduction and transformation do not require cell-to-cell contact. So just briefly reviewing some of our antibiograms here at Vancouver General Hospital, we see that when it comes to E. coli, there's only 55% susceptibility to ampicillin and amoxicillin, and we are seeing a growing resistance when it comes to cefazolin, ceftriaxone, ceftazidime, and Septra, which have moderate amount of resistance. And unfortunately, we do see that there is indeed a growing resistance to ciprofloxacin. Fortunately, we have not yet developed terrible resistance against peptazole meropenem. And we can actually see that nitrofurantoin here is a pretty good agent to use for otherwise uncomplicated UTIs. And just looking here briefly at the the E. coli strains in the ICU, we do see that the resistance pattern is quite significant. Here, when we compare it to the Lionsgate and Richmond hospitals, we can see that they are doing better than us in terms of resistance to some agents, but we do still see that common growing resistance to Septra and Cipro in both of these hospitals. I was also able to find this community antibiogram looking at urine cultures that were analyzed at the Life Lab over the course of the last year. And we can see that fortunately here, the resistance is not as terrible as it is in hospitals. With, ceftriaxone being okay, ampicillin not terrible, and similarly fosfomycin, gentamicin, nitrofurantoin being good agents. But unfortunately, there is also growing resistance here to Septra when we look at E. coli. So finally, here are some conclusions of this presentation. So understanding the pathogenetic underlying recurrent UTIs and the intricate relationship between host and pathogen offers avenues for the development of new prophylactic and therapeutic measures. Postmenopausal women are disproportionately more at risk of developing recurrent UTIs, and non-antimicrobial prophylactic measures should be discussed with patients to inform decision-making. And then increasing resistance patterns are seen with commonly used antimicrobial, and if needed, antimicrobial prophylaxis should be initiated but judiciously. So this concludes my presentation, and I'm happy to take any questions.